Good morning, everyone. Welcome, and thank you for joining me today for the second webinar on Clostridioides difficile. This is the fourth webinar in the HAI Superset series. Remember, jumpstarts are opportunities for facilities to gain fresh ideas, provide peer perspectives, energize your teams, and stimulate action around your infection prevention efforts. Before we get started today, I want to walk you through a few brief housekeeping items. Attendees are automatically muted. However, we highly encourage you to interact and use the chat box to ask questions during the event. You can see the chat box in the bottom of your screen, circled here. And then before you enter a question, make sure that you have your toggle set to all panelists and attendees. I also encourage you to use your phone or computer audio, but not both. If both are on, you will encounter an echo. Now to get started and practice using the chat box, who do we have in the room today? Please enter your name and the facility you represent. Hi, Cindy. Hi, Stephanie. Good morning, Kara. Hi, Jen. Lexi, Michelle. Hey, Chris. Kylie, Michelle, and Tanya from Franklin. Nancy Carper from Mercy One. Tanya from Mercy One. Lori, Joan, Deb. Kara. Good morning, Kate. Well, thanks so much for taking time out of your busy schedule to join me today. I hope you find the information that I'm about to share informational and actionable for your facilities. One other question, what do you prefer for Thanksgiving? Ham, turkey, or something else? Turkey, turkey, ham, Cornish hens. Not had those for a long time. Prime rib roast, but gotta go turkey. Ham balls. Oh, I love ham balls. Okay. Well, now that my stomach's growling, I think we'll go ahead and get started talking about C. diff. Okay. So, our objectives for talking about C. diff, rapid identification and diagnosis, ruling out CDI in patients with diarrhea, prevent transmission of CDI, establish guidelines for using contact precautions, establish, maintain, and monitor an effective hand hygiene program, environmental controls, monitoring, oh, new lips today, I think, guys. Monitoring environmental cleaning, antibiotic stewardship, in which will analyze antimicrobial use and determine appropriateness of selected treatment, limit use of antimicrobials through formulary controls, define and utilize best practices for process improvements, and finally, create peer-to-peer collaboration among hospitals. So last week we talked about what C. diff was and wasn't. We also covered testing algorithms and appropriate treatments for initial episodes of C. diff and then recurrent episodes of C. diff. This week I want to delve just a little bit deeper into contact precautions, environmental controls, antibiotic stewardship, and community-acquired C. diff infections. When I was doing research for the webinars. They identified that community-acquired C. diff is on the rise. And so I want to speak a little bit to that and find out what you all are doing to help offset those pieces. So again, why is C. diff important? It's the most common microbial cause of HAIs in U.S. hospitals, 453,000 cases annually. 57% of all CDI occurs in patients age 65 and older, and 10 to 30% of patients with a healthcare-associated CDI have recurrence. It's high on the mortality list, 29,000 associated deaths annually, and nearly 90% of those CDI-associated deaths are in patients age 65 and older. And then 9.3% of patients with healthcare-associated CDI die within 30 days of diagnosis. And again, as I stated last week, most of those patients have comorbid conditions, but there is an uptick in younger and non-healthcare associated infection out in the community. So we'll speak to that in just a little bit. And then, of course, the cost. The cost is a huge impact for facilities and healthcare in general, in that it's $4.8 billion annually in excess costs in acute care facilities. And that's either attributed to antimicrobial resistance, increased length of stay, and or readmissions for those patients. So when it comes to contact precautions, early identification of patients with CDI and those suspected of having CDI. I know last week several of you indicated that you have either enteric precautions or immediately put patients into isolation when they have or when they're suspected of having C. diff. Just out of curiosity, how many of you carry those infection control practices into your own clinics? Or do you work with the staff there to identify those people that could potentially have C. diff in the clinics? Just go ahead and type in an answer in the chat box. Okay, Steph, you indicated that you're not sure that there's anything in the clinics. Jan, you indicated that it's a struggle in the clinic. I would agree with that. Okay, I'm getting a few others that say that they're not aware of any precautions that are set up in the clinics. So moving away from the clinics, how do you communicate within the hospital setting for when patients transfer between departments for testing or procedures or something like that? Do you have a best practice alert that follows patients, or do you do a soft handoff or a warm handoff to the next department to say, hey, this person is suspect or identified as having C. diff? How do you guys handle that? Handoff? Okay. I'm seeing several folks saying that it's part of handoff. Ticket to ride. Sign-in room and handoff. Okay. So then, have you guys ever followed those patients to ensure that the next department is adhering to the specific precautions required? Or you do some type of an audit? auditing. Okay. Okay, Nancy, you indicated you review lab values for both units. So do any of you, or have you implemented CHG bathing for your CDI patients? Oh, Chris, CHG for all patients. Majority is pretty much saying no. I was just curious. I saw that as an intervention for patients with CDI infection because of the spore shed and that type of thing. So I thought that was an interesting concept. So just remember, spores can be spread directly or indirectly, and the best way to handle that is hand hygiene with strict adherence to soap and water, utilizing personal protective equipment such as gloves and gowns, and then ensuring that donning and doffing is done appropriately. So just out of curiosity, do any of you do annual doffing and donning education with staff, or just-in-time training with staff, or is it part of your skills fair, that type of thing? Yes? Yearly at the skills fair. Okay. Skills fair. Okay. I will tell you, I think that's probably the best way to do it. The other thing that I've seen done for when it comes to doffing and donning is to possibly videotape staff when they're doffing and donning their equipment. And then it gives them a real-time feedback of what went well and what didn't go well. I know I've used that in a couple of different areas where I've been at, and it really is very effective to just do a short videotape, and then staff can actually see and you can coach from what is observed on the tape. So just another idea. Suspect or infected CDI patient in private rooms with a private bathroom, dedicating patient care equipment. How many of you, when a patient is in enteric precautions, have dedicated patient care equipment? Or is it even capable? Are you even capable of having dedicated equipment on those types of patients? Okay, I've got several of you saying, yes, you do dedicate equipment. So just out of curiosity, how do you handle those patients that need to have fixed equipment, say an EKG, or potentially some type of a respiratory piece of equipment? Do you wait to do those types of testing, or do you have specific guidelines on how that type of equipment is to be cleaned? Tanya, you indicated dedicated during stay and thorough clean after visit. Clean with bleach wipes. Okay, I'm seeing several folks say that they use bleach wipes to wipe down that type of equipment. Very appropriate. And again, you know, as I said, possibly consider CHG bathing for those particular patients. And then, of course, signage. We all know signage is important, but I will tell you, at least from my experience in bedside practice, you can end up with signage fatigue just as much as you can with alarm fatigue. And so how do you guys get around that? How do you guys get around folks who don't necessarily adhere to signage precautions? And I'm thinking, you know, perhaps visitors and or providers. You know, I've worked enough bedsides that I know providers don't necessarily adhere to the signage because they're thinking they're not going to touch the patient. So what are some good tips you guys can provide to each other and share? Do you perhaps have patients or families, I should say, check in at the nurse's station first? Or do you really force the envelope with the provider and say, hey, you really need to adhere to isolation precautions because you need to set the standard for the rest of the staff? I have to say I've had that conversation with providers before myself, and while it's not easy, it is the best practice for patients, families, and staff to prevent transmission. So, okay, moving on, we'll talk a little bit about environmental controls. Carrie, you indicated that you have a hospitalist program and they always wear the appropriate PPE. That's good to know. I will tell you, I've seen a mixed bag when it comes to hospitalists in the facilities I've been in. Some are pretty good to adhere to it. Others are, again, they have the mindset, well, I'm not going to touch the patient, and so I don't have to worry about that. And sometimes, regardless of the education you provide, they just make up their own mind and do their own thing. So when it comes to environmental controls, we need to ensure that staff understand that any environmental surface can become contaminated, and CDI spores can survive on surfaces for up to 5 months. There was one study when I was doing the review and the preparation for this webinar that says 49% of hospital rooms occupied by CDI patients and 29% in non-symptomatic patients had spores in the room. Daily and terminal cleaning of high-touch surfaces, patient versus public areas, and then restrict patient movement. So some of those things that you can consider, you know, when you first get a patient in, is that you can consider commode liners. I know that the recommendation really is to have a private room with a private bathroom, but if that's not feasible, consider commode liners. And then we already talked about dedicated or disposable patient care equipment. Just out of curiosity, do any of you have fecal contamination cleanup kits for spills or uncontrolled stools? Yeah, I'm seeing a few people say no. I honestly have to admit I wasn't aware that these were even available. So I learned something new when I was doing this research. Audible timers. I know sometimes with the EVS staff, they're just so ingrained in completing their task and doing what they need to do and get moving on because they may get pulled to a different unit or they may have more discharges than what they anticipated and that type of thing. Have any of you utilized audible timers to give a tangible, real-time, evidence-based practice to the EVS staff to let them know that they really do need to keep a surface wet for the appropriate length of time. Have any of you ever implemented that? Yeah, I'm seeing several folks say no. I hadn't either, but I thought it was a unique learning opportunity, you know, especially for those new EVS staff that are just coming in and don't necessarily understand the pathology and epidemiology of some of the things that they need to clean. So just something to throw into your toolkit that maybe for those new folks, you can encourage them to use a timer to really get a sense of when something is finally terminally cleaned. I'll put it that way. And then clearly defining who is responsible for cleaning critical patient care equipment, such as IV pumps, EKG machines, ventilators. I know in facilities that I've been in the past, it's always been a point of contention where EVS staff were under the impression, if you will, that they weren't allowed to clean this type of equipment and that only nursing staff could, and yet nursing staff thought EVS staff was cleaning it, and so therefore nobody was cleaning it. Do you guys have something in your policy or your procedure as to who clearly is supposed to clean that type of equipment? And if so, who is it? Okay, Stephanie, you said you'll have to look. Yeah, you know, that might be one of those things that just simply gets overlooked. You've got the policy for how things are supposed to be cleaned, but there's no clear definition as to who should do it. Excuse me, Jennifer, you said that it's outlined in your policies for the departments. Jill, you indicated that nursing cleans it. Okay. That was kind of eye-opening for me when I first started in infection prevention, was staff really not knowing who should do what. And we all know that if one assumes the other's supposed to do it, it truly never gets done. So, and then Nancy, you indicated that you have a chart with a clear designation of who cleans each item in the room, and it is on their clipboards to follow. I love that. You've got something that's tangible and clearly outlines who's responsible for the cleaning of that. I love that. Do any of you use specialized privacy curtains for your patients that are put in isolation? And what I mean is those curtains, the privacy curtains that are essentially just rip away and where you don't have to take a ladder in and pull them down out of the hooks? Or do you potentially use disposable curtains? I've seen that come up once in a while. Okay, Chris, you said you've gotten rid of most curtains in patient care areas. Cindy and Lori said no. So just out of curiosity, if you do have curtains, do you have a regular schedule set up for those privacy curtains on how often they're to be cleaned or laundered? Okay, Lori, you said yes through EVS. Jen, you indicated there's a schedule, and if there's a patient in precautions, then the curtains are laundered after they're discharged. Cindy, you indicated that you have a schedule that the EVS director has. Okay, Chris, monthly or visibly soiled when you had curtains. Okay. if you don't have anything in place for that, I would just encourage you to just check on it, because again, spores can live on surfaces for 5 months, and so it's just something to consider when you're talking about transmission. So again, environmental considerations. How is the environment cleaned when a patient presents with suspect or verified CDI? We already touched on the dedicated patient care equipment and dedicated bathroom, and then just cleaning solutions. I know several of you indicated that you utilize bleach. Just out of curiosity, how many of you use a UVC light as a secondary measure to clean either specific areas or those patients that are with highly transmissible infections, and or hydrogen peroxide vapor? Have any of you implemented that? Okay, seeing several no's. I can see that for a good portion of our hospitals. I know unless you have a high prevalence rate and or infection rate, or you've got units that are really critical to ensure that they keep clean, it wouldn't necessarily be a step to have. But just out of curiosity, because it is coming more to the forefront. Jody, you indicated that you use a UVC light. Do you have certain indications as to when the UVC light is used? Is it specific to just certain diagnoses or a certain unit? I know I've seen where facilities that do have the UVC light, they use it for surgery. They also use it in their critical care units, whether it be surgery or surgical intensive care or cardiac intensive care. Jody, you indicated that EVS has a room rotation they use for every unit, and they use it for specific diagnosis for those patient rooms. Stephanie, you indicated that you have yours built into the OR. That's interesting. I've never heard that. So then I'm assuming that at the end of the day, once the terminal clean is done, then the UVC light is just put into effect. Is that correct? Okay. You do a lot of orthopedic procedures and you have them on during surgery. That's interesting. Good to know. To prevent infection. I would like to hear more about that. That's an interesting, I've not heard that in type of action with the UVC lights, so that's good to know. We'll move on. So I want to talk a little bit about antibiotic stewardship programs. So studies have shown that 30 to 50% of antibiotic use is inappropriate. And this includes longer than necessary use, treatment of non-bacterial diseases, such as viruses, treatment of contaminants or colonizers, and then duplicate therapy. So just out of curiosity, for those of you that have an antibiotic stewardship program, do you have indications for the types of antibiotics that should be used for C. diff? And then the other question I have is, do you, on your antibiotic stewardship program, or perhaps even as part of your infection control meetings, does EVS sit on those committees? Stephanie, you indicated yes. Jennifer, you said yes. Jill? Okay, so I am seeing that there is representation from EVS. I'm glad to hear that, because when I was doing research for this, I found mixed reports within the studies that EVS in some instances was included, and then in other instances it wasn't. And when you're talking about something like C. diff, it really is very important to have representation from EVS, because they play a critical role in reducing transmission of that particular disease. And so, Tanya, you indicated that they're supposed to come, but they don't. Yeah, I ran into that too. They either forgot, or they got pulled, or staff call-ins, and so then the director, the manager, representative was supposed to cover. So how do you overcome that for those facilities that are having problems getting buy-in or getting staff to attend those meetings? Any suggestions for Tanya or anybody else that might be having issues? That's a tough one to overcome, Tanya. I do agree with that. Okay, so next I've got some decision trees. And this one is from Jennifer at Pella, and I've got a few others that I just want to go through. But out of curiosity, I know some of you last week indicated that you have indications and things built specifically within your order sets. Do any of you find that providers and or staff have difficulty adhering to the order sets? Or do you have good success with, like what Jennifer has, a CDI decision tree? Just out of curiosity, Jennifer, do you have this laminated at the nurse's station? Is this in each of the patient's rooms, or how do you have this set up? Is it built within your electronic health record that it automatically spits out when somebody presents with this type of thing? Okay, so Jennifer says that she wishes but no, that she's done intensive staff training at meetings, at staff meetings, and it's also brought up in daily huddles. Okay. And so, as Joan indicated, is this a paper tool for you, Jennifer, or is this an electronic tool? Okay. I'll move on to the next tool. So this particular tool I found on the University of Wisconsin hospitals and clinics. This was something that they shared for their facilities. And again, it just goes through, I believe this one is paper. And if anyone's interested in copying or speaking to the particular person that developed this, the email contact is right here. But as you can see, it goes through, and this one is nice because it talks about hospital and ambulatory clinic precautions. So this is something that not only did they encompass within the hospital, but they've also done for their clinic. And then it also goes on to spell out specific precautions for staff to adhere to. It talks about minimizing, when you go down a little bit further, it talks about CDI disease prevention and drug-related recommendations. So it's got that pharmacy component that I like. And then it also goes on to talk about potentially those antibiotics that are at either low or high risk for increasing potential C. diff infection in patients. And so I thought this one was good. It covered all of the areas that I felt were pertinent when you're talking about prevalence and when you're talking about transmission and environmental controls. Thoughts about this one? Like I said, I just think it does a nice job of covering all of the areas that might potentially be impacted by somebody who has suspect or true C. diff infection. Jennifer, you indicated you like how it addressed the antibiotics. I do too. I do too. So, Michelle, you said it was easy to follow and you like the links for additional information. Yeah, it is a good setup. I think it covers all of the pertinent pieces that would be applicable to facilities. The next one is from Mercy One Dubuque, courtesy of Gail Gates, who's an infection preventionist. This is something that she developed and actually presented back in July through IHA on the Bright Ideas. I don't know if any of you were able to attend that, but there was some good information from facilities on various topics, and hers happened to be on Clostridioides difficile. And so again, she goes through and it qualifies what episode you're dealing with, whether it's initial or recurrence, and then goes through to talk about how the testing should be and what that testing piece looks like, and then the role of antibiotic stewardship in controlling CDI rates. So again, it's specific to identifying and treating. It doesn't necessarily speak to the staff component when it comes to PPE or environmental controls, but with a little tweaking, I'll bet you could add those pieces and make this a usable tool for everybody. So the next tool that I want you guys to take a look at is from the Minnesota Hospital Association, and this one is 2 pages. This one talks about, I honestly like how it's broke out by identifying the action, the procedures that are involved, the rationale, and then it goes through and defines who's responsible for it. To me, this was clear cut and it takes that question out of, for staff anyway, am I supposed to do this? Is somebody else supposed to do this? It gives clear expectations. So again, it's just another way to make sure that you're encompassing all of those pieces that are involved when you're dealing with a highly transmissible disease. Any comments about this one? I'll move on to page 2 and let you take a look at that. But it talks about the testing, it talks about the use of PPE, restricting patients' movements, that type of thing. Okay, moving on, we'll talk about a little bit to do with community-acquired patients, or community-acquired infections, I should say. So remember that CDI is historically considered a hospital-acquired infection. When I was doing research for the webinar, I found that a recent population-based study found 41% of CDI infections were actually community-acquired. That took me aback a little bit. I wasn't sure, I guess I wasn't aware that it was that high for community-acquired. The incidence for the United States indicates it has doubled. So CDI has doubled from the 1990s to 95.3 cases per 100,000 patients, which is quite a significant increase over the last 15 to 20 years. In the same study, they concluded that CDI affects lower risk populations, such as younger patients and patients that have had no exposure to antibiotics prior to 12 weeks before the onset of the infection. And additional factors that play a role include asymptomatic carriers. Those types of patients can have a ratio of as high as 7 to 1. So you can have 7 non-symptomatic patients compared to 1 CDI patient. Children younger than 2 can be asymptomatic carriers with colonization rates up to 70%. When I read that, I thought, holy buckets. 82% of patients with community-acquired CDI had some form of healthcare exposure other than hospitalization. So for instance, physicians' offices, dental clinics. I saw that come up a couple of different times when I was doing research, dialysis clinics, and then the ER. And remember, it's important to screen not only for recent hospitalizations, but other types of healthcare exposures as well. So with you all, when your nursing staff are doing their assessment and you're suspecting CDI, do you only ask about recent hospitalizations, or do you ask about other healthcare exposures? Only hospitalizations, Jennifer? Cindy, you indicate only hospitalizations. I'll be honest, in my practice, that's all I did was hospitalizations as well. Yeah, I'm seeing that with several folks. It hadn't dawned on me really to indicate or to consider other healthcare exposures for CDI, which I thought was kind of interesting. The other piece that we have to consider when we're looking at community-acquired CDI is that there are new virulent strains out. When I was doing this research, they had talked about the North American Pulsed Field Gel Electrophoresis, or NAP type 1. And I don't know if you all have seen this. I'll be honest, in my practice, I hadn't seen it. But if you have somebody who has this, it produces a higher toxin load. There's associated increased mortality, and there is substantial fluoroquinolone resistance with the NAP type 1. Other common strains that are seen with community acquired are NAP 4 and NAP 11. So I found that was kind of interesting, and it just coincides again with antibiotic stewardship. You know, we have to get a good handle on educating people that antibiotics aren't necessarily going to solve every problem they have, and our body is set up to have natural defenses, and by throwing antibiotics at them all the time, we're taking away our natural defenses. So one other thing that I saw that I found kind of interesting was probiotics. So when we've got patients who are on antibiotics, some providers are starting to also prescribe probiotics. Are any of you seeing that in your facilities? Chris, you indicate you give probiotics. Jody, you indicate that you don't. Tanya, your pharmacist usually addresses this during IDT. Yeah, Nancy, that's what I found too, is that some of the literature doesn't support that. Tanya, you indicated that you do on almost all. Okay. Here's what I found, and you can take it with a grain of salt, but when I was doing research, it indicated that in a meta-analysis of 20 randomized controlled trials of mostly adult inpatients, probiotics reduced the incidence of C. difficile associated diarrhea by 66%. Now that was roughly about 3,800 patients that this impacted. But then I found another study called the PLACID study, or the probiotic lactic acid bacteria and antibiotic associated and C. difficile diarrhea in the elderly. Man, that's a mouthful. Found that there was no difference in antibiotic associated diarrhea between the control group and those who received probiotics. So again, as with everything else, I think probiotics have a role. I just think that there needs to be more studies, if you will, on what's encompassed and what's appropriate to use those probiotics for. Just out of curiosity, do any of you use the Bristol stool chart? Okay, I'm seeing some folks use it. So, yeah, I thought I had this in last week's slide deck too, but I thought this is just a good, clear picture for staff to really tangibly think that, oh, hey, we may be dealing with C. diff if it looks like type 6 or type 7. So, okay. So I ran across this. This actually came from the AHRQ PSI CDI Prevention and Transmissions update. And this is their CDI top 10 checklist. So develop and enhance your ASP, evaluate the use of antimicrobials by infection type and or unit, evaluate antimicrobials among patients with CDI and provide feedback to providers and medical staff, developing processes to minimize testing, establish a lab-based alert system to immediately notify the infection prevention team and providers of new CDI results. Just out of curiosity, how many of you are flagged when there's a positive CDI result from lab? Okay, I'm seeing some no's. Chris, you indicate that all possible MDROs print in your office. Jill, you indicated sometimes. Nancy, you indicated yes. Okay. Is that something that could potentially be added to when the results are placed out? Would that be too labor intensive or difficult to build into the lab protocols so that you all would be notified? Yeah, I would agree with you, Jen. It does depend on the electronic health record. Well, that's just an idea to consider, you know, to have those MDROs print to you or to at least when the results are out to flag you to say, hey, we have a possible MDRO. And then remember that CDI is a clinical diagnosis and not a lab diagnosis. So the lab piece is just a portion of truly identifying that diagnosis for that patient. Establish cleaning protocols that are effective in eliminating CDI spores in the environment. Use a monitoring system to evaluate and validate effective room cleaning. And then engage and educate patients, families, visitors, and community partners on the prevention of CDI across the continuum. And then finally, establishing and maintaining an effective and engaging hand hygiene program. So one piece that I didn't talk about that I do want to touch on is what policies do you all have in place for employee illness when it comes to enteric types of illnesses? Are they required to be out 24 hours? Are they required to be out 48 hours? Do you require them to be seen by a provider before they come back? Okay, Jennifer, yours is 48 hours. Nancy, you indicated 48 hours after symptoms stop. Chris, yours is 24 hours past the loose stool. And in another facility you worked at, it was 48 hours. That's what I've always been, in the facilities that I've worked in, it's been 48 hours with no symptoms. But I will tell you, when I was doing infection prevention, I used to run into staff all the time that would say, well, I stopped after 3 o'clock in the morning and my shift didn't start till 3 o'clock in the afternoon, so I thought I'd be okay to come in. You know, and not fully understanding, again, the pathophysiology that if you have C. diff or some other type of infection, you could still potentially be shedding those bacteria, the virus, and or the spores. Cindy, you indicated 24 hours after symptoms stopped. So the other piece that I want you to consider that I ran into issues with too is your volunteers and your auxiliary. Do they follow this same policy? Yeah, I agree with you, Jen and Chris. They're supposed to. Some are better than others. And I know a lot of times with those auxilians or the volunteers, it's probably one of the only times that they're able to get out of the house. Yeah, I ran into that too, Cindy. There wasn't a good handle on it. And so just trying to get everybody on the same page. It's like herding turtles sometimes. So. All right, guys, we are at the end of our session. I appreciate your time today. If you have questions or concerns, don't hesitate to reach out to me or your clinical quality consultant. Next week, we will start our session on sepsis. And remember, that one is on Tuesday next week. It's not on Wednesday, but it is at 11 o'clock. And so the link for the recording and the slides will be sent out in the next couple days or so. Thanks so much for your time, and enjoy the rest of your day.